How this preset? Wait. Call it preset zero. Have you used preset zero? You have used zero. Have you used zero?
Yes.
Which this one or that banner? No. White. What's the preset for that banner? 12. That's on this one. And is this one now? Put this one now on that banner. Do you have it now? Go to the 12. Put
to the healthcare sector by reducing commitments made and also encouraging other
Go to the
collaborators
preset, type the preset. Do you have preset on it?
No, this one.
So do it if you don't have preset. Set preset on it. It's the one facing front. Go on, preset, full banner. Tokuma, you don't understand things. The big presentation. Go.
Through the leadership of Dr. Faisal and all collaborators
Go.
on the successful launch of this quiz intervention, and we wish you the very best.
Thank you. Save it now. Save. Take this. Save it now. Save it. Are you using 0?
I said 20.
20. You will remember.
Thank you very much.
Tokuma, I just done
We
that.
heard of the truth before then. I'd like also to recognize, very importantly, His Royal Majesty King Bubarai Bakolo from Bayelsa State.
The woman.
At this moment, we'll hear from the traditional institution and representing His Eminence, the Sultan of Sokoto, May Badi, Deputy Chair, Northern Traditional Leaders Council, Engineer Abubakar Umar Suleiman. I'd like to welcome your Royal Highness to the microphone. Please, let's make him very warmly.
Yes, thank you. All right. Take this one. Take it. Take this one. Leave it like that. Tokuma, follow it on that one, on that camera. Just adjust it. You adjust this one too. Adjust that one too. Adjust this. Take it this one. Take this one. Stop. Tokuma, stop. It's not in the center. So move this one out a little.
A nation that is healthy is better in any nation. So, the full support to the grassroots, because we love start at the primary healthcare level, local. So this will bridge the gap by this initiative. So thank you very much.
Take a wide shot, Tokuma. On this one, look at me. Take a wide shot from that angle. Take this one. So it's today. Take the backdrop. Do it quick.
Another round of applause.
Hey, Andrew.
And very nice, that's the kind of Google message that I have. Straight to the point.
Go to the woman. Adjust the woman. Balance the woman. This. I think we're still with
the Executive Secretary of Government Health Board or the Government Health Commission and all other protocols. I stand by what everybody has observed here. I am so delighted to be standing here to present my board. That is one of the most difficult tasks in civil service. For your boss to be seated and the boss said you should present him or her. You are history, you are pleased,
go to the minister.
So you don't know
this
who are.
officer is this one she's talking about.
So
Go to them.
I come here to present my
Going
voice.
quick.
And I'm sure I have to
Going
know that I'm
quick.
permitted and
But yeah, take it, Andrew. You're on here.
let me go straight to the field of another.
Yeah, take. Thank you. Well done.
Distinguished ladies and gentlemen, today marks a very memorable day in the lives of our people in the communities, where we grew up and also where we live. I also intrigued by the great intervention program. We see acronyms like teach, scarce, preach, etc. When I got the invitation to the launch of the preach, I was wondering what Dr. Meister that targeted at addressing one of the most critical challenges facing our health sector in Nigeria. The dearth of human resources for health, especially at primary health care. There is not a single country in the world that can boast of effective healthcare delivery without adequate and well-distributed human resources for health. No matter how much of a masterpiece the architecture of a health facility is, or how sophisticated the equipment are, or even the availability of the commodities, a healthcare delivery system will not function optimally if there are not enough skilled workers. For this reason, I think there is no better way to tackle the challenges of healthcare delivery in Nigeria than to close the gap on the equitable availability of skilled health workers in our PHC facilities. This can be achieved by creative measures such as the CRIP. This is the community-based health research, but account for 14% of the world maternal death burden. Similarly, our country loses 2,500 children under the age of 5 every day due to largely preventable causes, including
Come on, Andrew.
you can see why I told you that when you are about that, you have
Go back
things bothering you. You are afraid, you are jittery, and you are excited. So I've been directed on what to do now. When I go say I thank everybody. Something Lord commend the NHPCDA under the guidance of the Honorable Minister of Health, Dr. Osali, a member commission of Mr. President, in ensuring effective collaboration and provision of enabling environment for the attainment of global health practices in healthcare delivery in Nigeria. Thank you for listening and God bless you.
Take this one. I just took
Thank you very much.
Tokuma, your attention is not here. You are not here. You are just talking. You are not a participant. Tokuma, you are not a participant.
You see
You
when
are
you
not a
give
participant. Stop behaving like a participant.
So please a round of applause for representative and of course for all the women in the hall. Since you did not give us your votes to represent you at the National Assembly and be governor,
Go back to
we can at least appreciate the good work that you are doing. So another round of applause for Nigeria.
Take this camera, this thing that is clapping. Go back to you. So take this one now to that woman's side.
We are
You understand? Because the camera
and
is.
I think
You understand, Tokuma?
describing
Does
the
not
next
understand.
presenter is difficult to
That
us.
woman's side view. This
And
one.
oftentimes when we do things around primary health care development agency, we see that a pathway for development to improve healthcare digital services has been put in place. And during and also his time, we have witnessed a lot of innovation moving forward. I'm always proud to call him my brother and be associated with him. On your behalf, Your Excellencies of distinguished ladies and gentlemen, I'd like to invite the Chief Executive Officer of the National Family Healthcare Development Agency, who is going to be redefining, seeking to redefine excellency. But before you do that, he's gotten the support of the chair and the board of the National Primary Healthcare Development Agency. So can you please stand together with the chair and the board members of the agency? You have the microphone.
Thank you. Thank you, Excellency.
Hold on.
You know, guys,
What?
I was worried about having this event today because it coincides with the commissioning of Dangote's refinery in Lagos. I see all the rich men are on their way to Lagos. Only poor people that don't be here today. But looking into the crowd, I see a wealth of individuals that give me great pleasure. As the floor of my presentation, I want to
take it.
recognize His Excellency, the Vice President of the Federal Republic of Nigeria, here represented by no other than Her Excellency, the Minister of Women Affairs and Social Development, our sister, our mother, the first female Deputy Governor of Northern Nigeria, Her Excellency Pauline Kedem Taleb OFR. I want to appreciate the man who is the reason why we're here today, our father, our mentor,
Stand by the minister. We'll take
the father of primary health care in Nigeria.
Take this one.
Dr. Osago Emmanuel.
I'm coming. I want to share with you. I'm coming.
Whose guidance in the last few years have been unmatched. I want to appreciate His Excellency,
So you can go back.
the Governor-elect of the state, who is the only governor who is represented here today. Please extend our warmest regards to him. I want to recognize my brother, the Director General of the National Education Agency, who has always been with this agency, but his leadership did not shine as bright until we had a pandemic, and he was here with us all. Thank you very much for providing us.
Go back.
Your Royal Majesties, dear present, thank you very much for all the work that you do in our communities.
Let me forward it. I'm coming.
Distinguished ladies and gentlemen, in the interest of time, I will not recognize all the rich people that are here, all the important dignitaries that are here, but you are all recognized and you are very important to the NPACDA family. Can you give them a round of applause?
Take that applause. Take chat.
Meanwhile, I'm watching my staff who are not clapping. Now 1,000 naira. Just because you are retiring, doesn't mean that you are not taking that your needs. Thank you very much. So, Your Excellency, I thought I saw the presentation.
Yes.
Let me just
Take it. Yeah. Quite good.
The purpose of this presentation is to really bring down to earth what we are launching today, what redefining primary healthcare priorities means. This is the outline of the presentation, what we're going to be talking about. I'll talk a little bit about the background, a little bit of the statistics that you're familiar with. We'll talk about what we're doing as an agency and then finalize with a call to action. So this statistics is something that we're very familiar with, right? That although Nigeria has the largest economy in Africa, we also have the unenviable record of having some of the worst diseases, including the fact that there's nowhere else in the world where we have as many children under 5 dying from completely preventable causes. In a world where people are living to over 100, the life expectancy of the Nigerians still hovers around 54. And with the way we are going, we are not on track. We are not on track to achieve the sustainable development goals, nor are we on track to achieve universal health coverage by 2030, unless we do things differently. This is why, since the PAC summit of last year, we came back as a team and said, it's not enough for us to lay down what the problems are. We all know what the problems are. We all know what the challenges are. But what can we do as a federal Ministry of Health, under the leadership of the minister, to do things differently and lay the blueprint for the transformation of primary health care? First and foremost, we said we needed to assess how badly the situation was. This is why, for the very first time in the history of Nigeria, we conducted a comprehensive assessment of primary health care all across Nigeria. Then we did better than that. We now know that we stop fragmentation of primary health care, where we have forces between the national, state, local governments, saying who is responsible for primary health care anyway. Thank God Algon is here so that they can go back home with the message. But beyond that, we know that there is no way at national level we can sit down and come up with strategies that are completely sterile of context. This is why we work together with the sub-national level. We work together with the commissioners for health. We work together with the executive secretaries of primary health care boards. And then also work with our donors and partners to come up with a strategy that is Nigerian, a strategy that tells the way to go, that describes the pathway to transforming primary health care, so that one organization is not saying one thing and another is saying something completely different. We work together to come up with the strategy to transform primary health care. In the course of this presentation, we'll be sharing with you what this really means. But beyond that, we also look at how we can solve the problem. And this is why we are launching the CRIS today. So, I think somebody conspired to give me the older version of my presentation. I spent the whole night working on this presentation. I didn't do one of last week. Nevertheless, we'll work on it. No, don't back up. It's fine. We'll work on it. Yeah, this is not my presentation, but I'll just talk to it. And then we can address it later. Please back up.
Yes, sir.
Okay. So next slide. So we need a PAC assessment, again, working with the sub-national level. This distinguished minister, can we give our commissioners, executive secretaries a round of applause? Fantastic. Okay, so they say I should move to the center. Something to do with the lighting. No clue what I'm talking about. So we need a comprehensive PAC assessment for the very first time. And this is what the result says. The result does not show exactly what the situation is. Okay, I think this is, can we just take a pause? Please let me get it correct. Because this is very easy. If you need, I have it on my flash drive here in case you don't have it.
Go to your shot.
Okay.
Go to.
If I was a funny guy, I would have taken this opportunity to tell jokes. But I'm going
Take this.
You know how doctors are. Doctors are very good. Where's Rosa? Where's Rosa? Rosa, come and talk about why they're putting the presentation together. Let's give Rosa a round of applause.
Let me see.
Let her do it.
2205.
Don't forget it again. Keep coming.
So I need to close.
Anyway, that is from what you can tell jokes. So this is from to I'll say.
So
This says that the rich people can contribute to us, the poor people, to share before we leave here. So, ladies and gentlemen, you're warmly welcome. I don't get this kind of opportunity impromptu like this. I'm a comedian, I'm just a stupid person. So,
follow him.
whenever I say stupid,
Follow him.
and so, my boss imagines I can just step up and make this happen.
Okay.
But what I can say is that
We're good, right?
there's been a whole lot of work going on at NPHCDA for this launch. So I'm not surprised that whoever was trying to put this together was too sleepy to
Sorry? It is okay, sir.
do the right thing. But what I fear the
I'll do
most
it now.
is when he said we'll address this later. It might sound nice while you hear it. I'm looking around the room like, who is that? Who is that person?
Okay.
But
I believe we're good.
are we good now?
Flash. Okay. Take it.
Okay, fine. So we're almost up. So that's the only fear I have. He won't lose his job, but I don't think that's a joke actually. Our executive director
Okay. Oh,
is
let
much
me
more
share.
kind to us.
I'm coming. I need to share it
One
on
of
there.
the most
I can see
understanding
it. Let them know.
executive directors we've ever had. Please, while we are
Take that.
thank you. Okay, it's back up now. I thank you very much, ladies and gentlemen. We, the poor people, will be accepting your contributions.
Thank you. Thank you, Rose, for clarifying those comments.
Boss.
So the distinguished ladies and gentlemen, excellencies. So in terms of human resources, what we found out from the assessment that 70% of primary healthcare sectors don't have the required human resources. If you look at the number of medical officers, look at nurses, midwives.
Yeah, go on. Talk to me, sir. Talk to me.
Was that me? Yeah, okay. Commissioned extension workers. The shortage
Yes.
is global. This really is the situation. So little wonder that no matter how hard these frontline health workers work, they just can't meet the indicators. And if we continue to maintain these numbers of primary healthcare workers, then there's no magic, there's no way we're going to be able to attain the SDG goals. We're going to be able to achieve universal health coverage. Next slide. On service delivery, what we found from the data is that there's significant disparity. Overall, of course, we're not getting the kinds of service delivery, especially when it comes to antenatal care. Again, this is tied with the inadequate number of human resources, particularly nurses and midwives. But this is particularly acute in the northeast and northwest. Next slide. On infrastructure, approximately 35% of all primary healthcare centers require significant innovation. That is to say, they are actually not supposed to be used at all. Significant innovations are still required. In the last few years, we've done multiple assessments of how states are abiding by the PHC under one roof policy. And this PHC under one roof policy is part of the Seattle Declaration. working with the Nigeria Governors Forum, seeing how we can use a peer review system to encourage states to implement over a decade. Only 13 states have been able to achieve full implementation of the PAC under one roof. Details of the PAC scorecard 6 will be made available to you guys. So you can look, if your state is not there, you can move closer and check whether it is not there. I'm sure if you can see from where you are seated, it's just not there. Working under the leadership of the Honorable Minister of Health, post-2022 PAC summit, we came up with a 4-point agenda that is still on the left. What are the things that we need to do to transform primary health care? We made it clear that we have to improve access and service delivery. We have to improve health promotion and demand stimulation. We have to ensure that there's efficient program delivery and using the right enablers and capabilities to deliver on primary health care. What you have right here is a picture of what the minimum standard is as defined by the Honorable Minister of Health for primary health care, level 2 primary health care, that has the full complement in terms of being well fenced for security, has the utilities, water, electricity, you have staff quarters, you have the ambulance, you have drugs and equipment. This is what we would like Your Excellency to take back. So for those who are here and will be going back to the States, this is what the future of primary health care looks like. And a number of states are already achieving this prototype. I mentioned a short while ago that all of this is not a situation where NPHCDA and the Federal Ministry of Health, as government, have sat in Abuja and come up with strategies. We've worked with our partners, we've worked with sub-national level. And as we have a fresh team of governors-elect in 18 states, this document that we're going to share today is what they should be holding in their hands if they want to transform primary health care in their states. It shows clearly that our partners have signed up and believe that this is the way to go. That it is not just national, it is not just NPHCDA, it's not just the states. This is what we need to transform primary health care. So if any NGO comes to you and say they have their own small pet project, if it is not here, tell them no. This is the direction. We are tired of NGOs coming and telling us that they spent 5 billion, 10 billion in primary health care. And then when you look, you can't see it. This is the direction, and we are taking space to work together with everybody so we are all aligned. So if you are bringing your money, if it is not in this book, it is not coming to Nigeria. Can we give a round of applause to the Latching all to the priorities that we've set in this document, we've launched the script, this strategy. I know for those of you that know about chips, you say, what is it about NPHCDA and potatoes? Crispy chips. But this is not about NPHCDA. Again, this is a multi-stakeholder, multi-sectoral collaboration. Federal Ministry of Health, the NPHCDA, our teaching hospitals, federal medical centers, the state ministries of health, the state primary health care boards, local governments. We've worked over the last 4 years to get to this day. So this is not a journey of just 1 year. We've been working on this for the last 4 years, along with the heads of departments of community medicine across the country. Can we give them a round of applause? So this is indeed what this community-based research, innovative training and services is about. It's really about how we optimize the high quality of workforce in our tertiary institutions to come to where we are finding where we have a deficiency in the primary healthcare sectors, so that not only will they provide quality service, but they will help with innovative training, mentorship, and carry out research that is contextualized, research that is our research, not research that was done in America and then you are trying to bring this here. It is research that is based on what you are seeing in the communities, that you can feel practical research. So we have a situation where we have top quality people coming to our primary healthcare centers, and we're hoping that in the nearest future it will be possible for us to carry out some simple surgeries even in our primary healthcare centers, just because of the quality of people that we're having. This is about partnership, it's about linkages. This is why it is very important that we also have the National Postgraduate Medical College and the president here. Can we give Professor Chidobe a round of applause? Thank you for the collaboration. So what does this really mean in practical terms? What it means is that for every primary healthcare facility that has been identified, we're starting off with the teaching hospitals, but we'll gradually look at the federal medical centers that have the capacity to provide this kind of support. We will have, for example, when you look at the top left, resident doctors, especially starting with those ones in community medicine, will come for their practice. We'll be able to engage, and at the minimum, we'll be spending about 5 man-hours a week per facility. But we're also recruiting additional human sources to specific primary healthcare centers. We're recruiting skilled birth attendants, so nurses, midwives, community health extension workers that have been trained on how to manage their situations during pregnancy and delivery, of course, under supervision. We're bringing in medical officers, recruiting medical officers, and also in our collaboration with the NYSC, we are asking them to prioritize, and this is something that they have agreed to do, to prioritize primary healthcare centers for the deployment of NYSC doctors. What does this really mean? It means here we are, we're bringing high quality staff from the teaching hospitals, but also re-energizing and reactivating the successful midwife service scheme of the past. But the difference between what was in the past and what the future holds for us is the fact that we have now imbibed in it a sustainable way. The reason why the midwife services scheme failed is because the sustainability aspect of it was not completely foolproof. So we allowed the states to take over, I think, after 2 years. And then, of course, the states could not pay the salaries. But with the current program, not only are we bringing in doctors and community health extension workers, but we've also ensured that sustainability, at least for the next 7 years, is assured. So what is the operational vision for the PRINCE program. We're hopeful that before the end of 2023, we will have recruited 3,806 nurses, midwives, and chiefs. And by 2030, we're looking at closing the gap to about 25,000 of these individuals. That we're going to be covering all teaching hospitals and institutions across 37 states. By the end of 2023, we would have covered 1,643 primary health centers. But by the end of 2030, we hope to have covered each political ward with these human resources. Of course, we're going across the 774 primary health, 774 LAs. You see the changes as I wind down this presentation. What does this really mean? What's the call to action? The call to action is that, especially because we are accepting across the states a new governance and governors who are returning, we need the political will to prioritize primary health care and make sure that we bring in the human resources that are required to drive primary health care. I said a couple of days ago that this is the only opportunity that any government has to actually do something significant about the human resources and primary health care level. And the primary health care level, all across the states, we find people who don't have the capacity. They've been deployed there as political agents. They are there in primary health care centers. It is only when a governor comes into office or is coming in returning, that is the only thing that he can weed out those elements and he will survive. If you live too close to the next election, you will lose your election. Because those people that you are weeding out have very strong political questions. If you move them, they will wait for you at the house. So please, distinguished ladies and gentlemen, in your conversations with governments, tell them it is now or never. If they don't do it in the next 1 year, if they don't audit the system and take out those people who don't belong in the primary health care system, it will be too late. And we've seen it happen. I've been here long enough to see it happen. They procrastinate. They say, don't worry, we do it. We do it. Until a year before election. If you have them, it's not possible. Multi-sectoral collaboration is important. You all know that we don't have to be here, we can work together. It's very important as well to focus on financial risk protection. The biggest challenge that we have is that 78% of our citizens pay out of pocket for their health. Thank God for leadership provided by the Honorable Minister of Health to ensure that the National Insurance Health Act was signed into law. That's going to make a difference. And then finally, the call to action is, yes, we are asking for more money, more investment in health, but we should also ask the question, can we get more help for the money that is already there? Can we ensure more accountability for the resources that are provided? I don't need to delve into that. I'm sure we understand what I'm talking about. We have to close the gaps. We have to ensure probity and accountability. And that is what we're doing at NPHCA. And this is why just last week we celebrated Gavi Global Forum BSGF coming to fund NPHCA directly because they are now satisfied that we have a financial management process that meets global standards. I'm comfortable. Finally, today we are going to be launching 6 books documents. all due to the incredible work, the profound work that staff at NPHCDA, the directors, the staff at the State Ministries of Health, the State Primary Health Care Board have worked so hard with our tertiary institutions.
She's amazing.
But like many of us, she dreams of more.
Imagine that dream takes her to the big city.
Don't have to imagine. This is what happens time and time again. She might get a job at a private clinic. Maybe she moves abroad to chase the dream.
Look, here she is in London.
She's working in a hospital.
Now imagine what's happened to us.
The people she left behind.
My wife died when she gave birth with no health workers around her. Nobody in our village gets vaccinated.
Our children are dying from pneumonia and diarrhea.
We don't know how to protect ourselves from HIV and malaria. It will only take one health worker to show us. There are 2,000 people in our community, yet we don't have a single health worker.
Where is the health worker? Where is she? It's hard to imagine a billion people.
It's hard still to imagine a billion people without a health worker.
Okay, Sarah, imagine this.
Imagine she stays. What would it take to make her stay?
Imagine investing in her. Imagine paying her a living wage.
Imagine giving her quality training that she can pass on. And imagine giving her the proper tools for the job.
Now she's got support.
She feels safe. She's also got the respect of the people around her.
We listen to her and we learn.
She is important to us and we value her.
Imagine what would happen then.
Over the years, she could save hundreds of lives.
She could inspire and train hundreds of others to become health workers like her.
I could be one of them.
So could I.
Each of us could be saving lives in our own communities.
Imagine
that. And then imagine what happens next. And then
a health worker for everyone, everywhere. Imagine that.
Now, help us make it happen.
Imagine that you don't have to spend out of pockets. Imagine cribs transforming not just as a snack, but Nigerians enjoying a strengthened primary health care, providing effective quality healthcare services through collaborative training of healthcare workers, provision of services, and research at the primary healthcare level and community level. Imagine what that will mean to building a healthy herd of Nigerians. Please let's once more appreciate the Executive Director, Primary Healthcare Development Agency, Dr. Peter. And I think one of the contexts in which he spoke, and spoke emphatically, is that of partnership. And just during his presentation, we had some strong partners came in. I'd like to recognize Dr. Gafar, who we call the legend for health financing. Dr. Gafar of UHC 2023. Please, can you rise for recognition? Thank you. And also from the Pathfinder International, working at the community level too. We have the country representative, Dr. Amina Durai, here. Thank you, you're welcome. Partnership, collaboration, that's the way to go. One individual who is feeling very happy with himself today, I can tell I have felt his pulse. I think it's normal, from my perspective of not being a doctor, but he's a happy man today. And why? Because we're cascading definitely and deliberately all that we can make happen at the health sector to the community level. And I think this is one legacy he wants to leave behind. Welcome with me, our chief host for today, the Honorable Minister of Health, Dr. Isaju Ihamure.
Healthcare at that level, you're going to be far away from universal healthcare. And so the representative of the Vice President, my dear sister, I would say, Mrs. Pauline Tallinn, the Executive Director of NPCDA, all our very prominent guests, including the governors-elect, heads of agencies, and distinguished ladies and gentlemen, I want to rest on the protocol that has been established several times. I also will join in welcoming everybody to this official launch of the Community-Based Health Research, Innovative Training and Services Program, CRISP. Dr. Faisal has a large number of acronyms, all of them dedicated to very specific topics and also quite befitting of each one. The other day we just had the scales 3 for the vaccination. And I want to start by commending the President of the Federal Republic, His Excellency Muhammadu Buhari, who I can tell you, as a Minister of Charge of Health, has actually set healthcare as a priority. The health and well-being of Nigerians with financial support as we have not had before. And for this administration, I would say that health really is wealth, and it was intended, his dream is that it will reach all Nigerians, which we are all struggling to do. Nigeria faces challenges of inadequacy and inequity in the distribution of healthcare services, particularly the human resource for health angle, and more particularly skilled attendants, doctors, nurses, community health extension workers in our primary healthcare facilities. 70% of the disease burden lies that's the weakest area of healthcare. That is paradoxical, but that is what we are facing. And perhaps after my speech, we shall again take a very short look at why is it that where the problem is, it's not where the main investment is going, and where we are all running to solve the problem. We have spoken about the indicators for Nigeria, very poor. We are supposed to be a rich country, but we do not have the statistics that actually show that we are rich. We have the worst health indices. And we must ask ourselves why. Why is that so? And find solutions to that. Working in primary health care centers, as one of the problems appears to be, is perceived by many people as unattractive, and I think that's probably a global problem. Why you also have in Europe and developed countries, there are gaps in rural areas, but they have the facilities and the whole system present. Just the human resources they are looking to complement, and they go outside to go and invite healthcare workers to have very quick and fast, immediate solutions to their problems. But here, our own difficulties are across the value chain, from the structures. We heard just now that 35% have almost of population, have almost nothing like a healthcare institution at all. So the preference is for health workers to go to urban settings, and so that in addition to the challenges of inadequate and inequitable distribution of skilled healthcare workers, you also have the problem of desertion from primary healthcare facilities. So we do have a problem of internal brain drain from the rural areas to the urban areas. So brain drain is not only when you go outside, but it's also a problem that is domestic and which we must find ways of making differently. In this situation, therefore, no matter what the investment is in building and equipping health facilities, if the skilled workers to provide the needed services are not available in the correct numbers and proportions, there will be inadequate care for the people. And you have heard all the attempts we have made to make the primary healthcare level attractive by building staff quarters, ensuring that in the new design, there is a new design that we made, there is provision for solar power. So you are not looking for money for diesel or for petrol for your generators. You have solar power that gives you light, you have water supply, you have staff quarters, and you have a good supply chain management. And of course, the financing mechanism is coming on board gradually. And in fact, the icing on the cake is the provision of a transport system, a tricycle ambulance system in each primary healthcare center to help with moving patients who cannot move at odd hours of the day, emergencies, and those who just cannot be transported at certain periods. So if we had those facilities ready, then the next problem will be the complement of human resources. Do we have them? And this is what this particular meeting is about. How do we get the human resources even if everything else is in place? Now, to address the challenges generally, in March 2022, the Ministry of Health and the Primary Healthcare Development Agency they convened this summit on reimagining the PHC in Nigeria. It was very successful. The attendance was very high. The 4-point agenda for the PHC transformation proposed to focus on improving access to service delivery through PHC revitalization. One per political ward, and one functional. I always put the word functional because the mere structure is not enough. And then you have, of course, a network of primary health care centers reporting to a general hospital in the local government. And we have been talking, of course, Dr. Faisal did make much of that in his speech, of using digital technology, telemedicine, that even a PhD center, you can do remote consultation with a doctor who is at the primary healthcare level, not at the general hospital level, to talk to patients and give preliminary treatment and diagnosis. And of course, the question of the circulating doctor, even if you have one doctor who goes around place to place, so that if you cannot afford one doctor for every PSC, you can have one who goes around maybe once a week to visit and be physically present, to see, which is taking healthcare to the grassroots is extremely important factor that is still ongoing. One of the strategies rooted, committed, multidisciplinary primary healthcare workforce, supported by an effective management system, by supervision and enabling environment that's created. I must also mention at this point that one of the ideas we had was to prioritize recruitment of healthcare workers at primary healthcare level from the communities themselves, training them, and then returning them to the communities they come from, so that the risk of attrition of healthcare workers is reduced. So that is hopefully something that will be taken on board by incoming governments to make sure that you don't necessarily take someone from an area to where he's not comfortable. You will not retain him for very long. So I am pleased to inform that the Community-Based Health Research in Innovative Training and Service Program, CRISP, which is being launched today, is one of the strategies for achieving the first of our 4-point agendas on PHC transformation. CRISP is a new partnership among the National Primary Healthcare Development Agency, our tertiary hospitals, federal medical centers, the state primary healthcare boards, and the local governments. And I'm happy that the local government is here because they are very, very close partners here in realizing this. And of course, the communities themselves. So you see that this is a partnership that goes across the entire tier of governance, both the informal at communities to the formal at federal level. And it is all to support the PHC development. Now, this initiative will leverage our teaching hospitals and our federal medical centers to pool skilled healthcare workers to the primary level in our communities, where they will routinely provide services and mentorship, as well as build capacity of resident primary healthcare workforce. Make primary healthcare work more attractive. And staff must also be made comfortable, as I said, by having quarters, by having potable water, and by reliable electricity. Here we have preferred solar power. The technology has improved so well now that it's very reliable and gives you the power that you need to at least take care of basics. Now, the CRISP has been conceptualized to lend momentum to the realization of the global vision and achievement of universal health coverage and incremental improvement and upgrade in the quality of service delivery. That must be one of our targets too. Not just build, but aim for incremental improvement. If you are not seeing any improvement from period to period, then you are not doing it right, because the world is moving ahead, and if you are staying in one place, you are left behind. So Dr. Faisal has taken us through this very important technical detail of the initiative, and I do hope that all the incoming governments will key into it and drive it forward. It is very important because we know that, as I said earlier, 60% of all the ailments and the main killers, we hear of a very high under 5 mortality in our country. The main killers are malaria, diarrhea, and pneumonia. Those 3. And they can all be handled at PhD level if you can get it in time and have a competent person. And that will crush your under 5 mortality. The same for maternal mortality. That level, questions with pregnancy, antenatal is free. You're supposed to go for antenatal, at least 3 of them. You can get your prevention of malaria that's given to you at the time of pregnancy to prevent malaria in pregnancy. You can get your HIV testing to know if you're going to have a child that will not get infected. So all those are basics for antenatal. Basics offered, free, if the PHC is working. That alone will reduce the number of HIV, children born with HIV, or the number of women who are dying during pregnancy of malaria, and many other problems. And of course, during delivery itself, you have the complications that come up, from heavy bleeding after delivery to obstructed labor during delivery, also the very dangerous things like, in fact, ruptured uterus, or eclampsia, all those issues which, if you didn't have a history, you would not be able to know that you have such problems in you. So you can, with a functional primary health care, you can reduce all these indices. Now, if it's that straightforward, why are we not all rushing to build primary health care centers and saturate the whole country? I'm not sure. I think it's political will, but while the political will at federal level is there, we would like to see this political will also at state level, at local government level, and among the communities. And as important as it is, I want to urge all our traditional rulers here present and all local government chairmen, all community leaders, religious leaders, of any government you get, ask for your PAC. You are entitled to 1 primary health care center per ward. So ask your governor that you want your PAC. Ask for it. If you don't ask for it, you may not get it. So therefore, the prioritization needs to be followed by active request. Anytime pay a visit, say we are looking for our PAC, and it should be the functional, complete PHC. And it is from there that the health issues of our country will begin to find the solution. And then the development of secondary health care, luckily, we have partners who are pledging to support us to develop our general hospital, 1 general hospital per ward, per local government, where you can do intermediate surgery. It's tied into the basic minimum package of healthcare services that's provided by the health insurance agency. So even if you're going for appendix or operations for pile or hernia, all those things can be at the general hospital level. You don't have to go to a teaching hospital, which can be 5 or 6 hours ride away on a bumpy road and very expensive transport. You don't need to do that. If you had a proper system, even basic minimum intermediate surgery can be at the level of general hospital. And the most minor ones, like wound repair, can be done at primary health care level. Dr. Faisal mentioned it. A well-trained nurse can suture a wound and clean it and suture it properly. You don't need to go to a very far away place that will cost you more money and waste your time. So the responsibility of ensuring that we have a strong health system that relies on one another. Of course, the ambulance system that serves all of these levels. For me, I'm passionate about it because it just simply makes sense that we go that way. It makes sense that we begin reading the alphabet from A. You can't read the alphabet from J. You have to read from A, and that is where strengthening the primary health care and its downward integration downstream to the CHIPS level, to the community level, with even health posts or health dispensaries at communities and the primary health care center at the ward headquarters. Then the connection to the general hospital. If you have all that, then you leave the tertiary hospitals to research and complicated surgery and neurosurgery and all those very complicated things that they want to settle down to do also. Okay, right now, most of the attention in our teaching hospitals is huge outpatient because everybody is going there who should be at the PHC. Thank you for your attention.
Thank you, Honorable Minister. Let's appreciate him one more time. You can see that it was not just a paper presentation, it was him asking us to jump on the train of CRIPS to ensure that health facilities are functional and that we have the right people doing the right things, and it's a collaborative effort. It's not just about primary healthcare development agency or the minister or the office of the minister, but it's a continuum and an assurance for us to be able to get improved healthcare at that level. Another round of applause for the Honorable Minister. Human capital is very central to development, and I think that's why this program is so important to improving healthcare delivery service. And so on your behalf, Honorable Minister, sir, Your Excellencies here present, very distinguished ladies and gentlemen, on our behalf, I'd like to invite for the keynote address His Excellency, the Vice President of the Federal Republic of Nigeria, Professor Yemi Osinbajo, SAN, GCON, who today is ably represented by my sister, whom I'm very proud of, and the Honorable Minister of Women Affairs, Dame Pauline Talley.
Thank you. Please be seated. The Honorable Minister of Health, my closest collaborator and a dear brother, Dr. Asagi Enahire, the Executive Director of Primary Healthcare Development Agency, Dr. Faisal Shaib, we appreciate you, and it is sad to know that he's the only governor that is elect that is, has been represented here. This is a program that is more focused at the sub-national, and we needed more governors here, chairman of Governors Forum, and all those managing the state and local government affairs. Country representatives of UNICEF, our close partners, World Health Organization, development partners, civil society organizations, representative of Dangote Foundation. I want to especially acknowledge the presence of all state commissioners here present, our medical directors, representative of our royal father, our dear eminence, the Sultan of Sokoto, all other royal fathers here present, head of agencies, the private sector, invited guests, ladies and gentlemen. I'm sure when the video was being presented, you will agree with me that when we talk about primary health care, the woman is the center focus, especially the girl, education of the girl child. The education of the girl child is key to the success of primary health care because mothers are the caregivers of every family, and an educated mother will ensure that her child is taken for immunization. She will ensure that the right meal, everything is given. So I'm happy our royal fathers are here. Ensure the girl child is educated in our communities. Our religious leaders ensure that the girl child is educated so that we can have a more educated community where the primary health care will be effective. I stand here to represent the Vice President of the Federal Republic of Nigeria, Professor Yemi Osinbajo, who would have loved to be personally here, knowing his commitment to the primary health care in this country. But official matters has taken him out of the country, and he said, I must be here to stand in for him. I therefore appeal to you, when you hear I, it's not Pauline Talen. Just imagine it's the vice president you are watching. So all the I's is referring to the vice president. Today, we mark a very memorable day in the lives of our people, our communities, where we all grew up and lived. The launch of the CRIPS program today is yet another innovative program targeted to address one of the most critical challenges facing our health sector in Nigeria, which is the dearth of human resource for health, especially primary healthcare level. Today's program is a call to action by all stakeholders, especially those working at the subnational level. The governors, the chairman of local government. I'm happy the representative of Algon is here. I pray that this message gets along. I wish all the 6 geopolitical zones were fully represented by Algon. But we trust and believe that the message will go down. Delivery without adequate and well-distributed human resource for health. No matter how much of a masterpiece the architecture of a health facility is, or how sophisticated, cannot function optimally if there is not enough skilled workers. For this reason, I think there is no better way to tackle the challenges of healthcare delivery in Nigeria than to close the gaps on the equitable availability of skilled health workers in our primary healthcare facilities. This can be achieved by a creative measures such as the CRIPS, which is the community-based research, innovative training and services program. I am aware that Nigeria makes up only 2% of the world population, but accounts for 14% of the world's maternal death burden. Similarly, our country loses 2,500 children under the age of 5 every day due to largely preventable causes, including the lack of services that skilled birth attendants could have provided. It is of interest that 80% of these death burdens occur in the primary health care and our community levels. This clearly justifies the need for urgent actions to be taken to implement the CRIPS to address this situation. I can confidently tell you that President Muhammadu Buhari and my humble self are ever compassionate about interventions that would help to improve the health and well-being of the Nigerian people. And I have no doubt in the capacity of Dr. Faisal and his team working in partnership with the academia and the teaching hospitals, which will help implement and get the desired results from this initiative. This initiative will not only make skilled health workers from our teaching hospitals and federal medical centers available to offer services in our primary health care centers in all the states of the Federation, but will also leverage on ensuring capacity transfer to and mentorship of primary healthcare workers, as well as promotion of best practices in community health. It's my belief that the effective implementation of this initiative will help to fast-track the attainment of universal health coverage, as well as reduction in preventable maternal and child mortalities in Nigeria. Working together is key to the success of primary health care. Collaboration is apt, and that's why we are all gathered here. May I therefore, on a resounding note, commend the National Primary Healthcare Development Agency under the guidance of the Honorable Minister of Health, Dr. Osagie Ehanire, for his well thought out initiative. To our development partners, I thank you most sincerely and assure you of the continued commitment of Mr. President in ensuring effective collaboration and provision of enabling environment for the attainment of global best practices in healthcare delivery in Nigeria. Thank you for your attention and God bless.
May I please invite members of the High Table alongside with representative of His Excellency the Vice President, while I invite Dr. Agwe to please speak on the publication and the launch of the documents that we are going to make public now. Thank you so much. Please make your way gently to the upper deck. Thank you.
Give them the mic over there.
Yes. Yes, you have the
Good afternoon, distinguished ladies and gentlemen. I beg to stand on existing protocol already established. So we'll be launching 7 books today. We will launch the CRISP strategy document and implementation guideline. The strategy document outlines the strategy direction for the collaboration between community-based medical education training programs, MPHCDA, states, and communities for collaboratory strengthening primary health care service delivery, research, and training. The implementation guide outlines the implementation steps to ensuring the critical gaps in HRH, that's Human Resources for Health, for PHC are addressed to ensure that at least one level 2 PHC per ward meets the minimum required HRH requirement in line with the revised World Health Strategy. The strategy document for PHC revitalization in Nigeria aims to improve access to quality healthcare service delivery through PHC revitalization, promoting health promotion and demand stimulation, ensuring efficient program delivery of the world minimum healthcare package, and establishing the right enablers and capacities to support the strategy's implementation. We also have a facility and financial management toolkit for primary healthcare, which is paper-based, and also an online PHC facility management set of documents that will provide easy, hands-on guidance to assist primary healthcare centers in Nigeria in performing their critical management and financial tasks. We are also launching the implementation guide for reproductive, maternal, neonatal, the implementation guideline for the RMNCH and quality of care developed by NEMCHIC, which is a modality for accessing safe, efficient, effective, timely, equitable, and people-centered care. We also have the PHC under one group implementation guideline and scorecard 6 report. Thank you very much.
Your Excellency, ma'am.
Okay. Your Excellencies, the Honorable Minister of Health, distinguished ladies and gentlemen, on behalf of the Vice President of the Federal Republic of Nigeria, Professor Yemi Osibanjo, it is my singular honor and privilege to launch the CRIPS. So there are too many. Which one do you pick? I will pick the one with the lady. Okay, can hold it. We pray that with good collaboration, primary healthcare will be taken to the next level, where every home, every village, every community is properly equipped with the right skilled workers. Thank you.
Okay. And then we'll move to panel discussion.
It's so good to see you too. Yeah, everything is fine. How is Ado? Well, yes. Hello.
Your Excellency, ma'am, please, the final pictures, please, here. Yes, yes, ma'am. Please, can we have board of directors, the chairman and board members to please come out, and the expert review committee to also join in this next group photograph. Thank you. Who?
Professor Shibogu, NGTAC. Traditional leaders present can join in this photograph. Can you help me ask you which other groups? Apart from the directors. Directors from the Federal Ministry of Health. Okay. These directors of Federal Ministry of Health, yeah. Directors from the National Primary Healthcare Development Agency. Please join the photograph session. Yes. Okay. Honorable commissioners from across the country, executive secretaries of primary healthcare boards, please join the photograph. Okay. The CMDs and the CMDs present, please get set to join. The HODs, Please join. Yes, some can join from behind and be on the rostrum. Okay, directors, thank you very much. You can move the ESs so we don't have a crowd. So, doctor, is there any? Okay, thank you so much. Thank you very much. You are highly welcome, all of you. Yeah? Development partners? Yes, development partners here present can have their own photo session. Please, our partners. Yeah. Development partners only, please join.
Okay, let's finish. Let them finish.
So if the crowd is too much, can some people go behind so they can be on the rostrum? Yes, I think it will be better.
Please, we are taking these photographs in groups so that it's organized. Now everybody is here. First, let us start with the development partners. Then we will have with the CMDs, okay? So if you are not a development partner, can you just step aside and then you will be the next batch? Okay, after that, we will have, who is the next group? Huh? Okay, so see, okay,
So development partners, CMDs get set later. Thank you very much. Thank you very much. Now, CMDs, can you join? Join up. And HODs.
Yes. Can we take the last bit, because I understand the VP's representative has another engagement. Congratulations.
I want to snap with female CMDs and women in.
Please, all the women, the CMDs, commissioners, all the female women in the health space, please can you come up? Where is Professor Ejembi? Professor Ejembi, all the women, please. Female commissioners, female CMDs, all the women working in the... And yes, and all the he for she's, yes. Yes. Professor Ejembi, please. Okay. Thank you. Women in health, yes. Professor, yes. She's there. Okay.
Congratulations. No, I'm going to say. Shall we please rise for the national anthem? Shall we quickly do that, please? Can we have the national anthem, please? Thank you very much. Congratulations. The program, the event continues. Please, we just want to bring to the notice of the CMDs, heads of departments, executive secretaries, honorable commissioners, please kindly complete your registration at the desk outside. Your Royal Highnesses, we thank you. Thank you. Thank you for being part of this. We are quickly going to move to the panel discussion. You can stretch your legs for a second. I'd like to bring on, I don't know, it's so difficult to announce him as a moderator, but I'm going to bring on Professor Oshibagun, President, National Postgraduate Medical College of Nigeria, who is going to chair the next session. Shall we please all settle so that we can finish in good time? Yes, sir. Please take your place. Can we settle down, please? We are going in for the panel discussion, and the chair for the first panel discussion is Professor Akin Oshibagun, President, National Postgraduate Medical College of Nigeria. I'd quickly like to announce, please can I have to this side of the hall, the panelists, Professor Chikake Ogbonna, Chairman, Faculty of Public Health and Community Medicine, National Postgraduate Medical College. Can we welcome him warmly, please? I'd also like to welcome Dr. Usman Mohammed Adis, Chair, Executive Secretaries, State Primary Healthcare Development Agency. Also, I'd like to invite Honorable Aminu Muazu, Chairman, Lafia Local Government and Deputy National President, Algon. I'd also like to invite Dr. Fumi Koka, who is representing Dr. Oyebanji Filani, Chair, Honorable Commissioners of Health Forum. Tommy, she's the one. Okay, thank you. At least we have one woman, just one. But thank God. Thank you. I yield the floor to Professor Oshibagun, sir. Please, can we all settle down for the panel discussion? Thank you. Please, I'd like to also invite Dr. Salma Anas Ibrahim, Director of Hospital Services, or her representative for the Federal Ministry of Health. Okay. She would join us later. Please, can we have the panelists go into action? Right, sir.
Well, distinguished ladies and gentlemen, good afternoon once again and welcome to this panel discussion. I'd like to thank Chief Mrs. Moji Makonjola for introducing us. Your Excellencies, it is indeed a privilege to be opportune to have this platform to contribute to our national efforts to improve primary health care delivery to Nigerians and enhance their health status. For me, personally, today is a very exciting one because 30 years ago, I headed the Community-Based Medical Education and Services Program in one of our state universities. So I'm excited that the National Primary Healthcare Development Agency is taking it forward by launching the CRISP program, which is more or less an update on the COPMES program. It stands the chances of increasing the availability of human resources for health at the primary healthcare level. Primary health care remains the best strategy and structure to help achieve optimal health outcomes for Nigerians in a sustainable manner. This is recognized in both the National Health Policy and the National Health Act, in addition to the law establishing the National Primary Healthcare Development Agency. The NPHCDA and its partners are to be commended for designing strategies to reposition the delivery of PHC services in Nigeria. The current CRISP strategy aims to improve access to PHC services in general, but with particular attention to reproductive, maternal, newborn, child, and adolescent health. It focuses on human resources to deliver these services, as well as on research to generate evidence for decision-making and innovative training. This distinguished panel of experts have been assembled to shed more light on aspects of the CRISP program and how their respective institutions will contribute to its success. I'm privileged to have on this panel esteemed professionals, starting from the Commissioner for Health for Ogun State, representing the Commissioners for Health, the Chairman of the Executive Secretaries of State Primary Health Care Boards, the President of ALGON, the Association of Local Governments of Nigeria, and I think the Faculty Chairman of the Faculty of Public Health National Postgraduate Medical College, that institution saddled with responsibility for postgraduate medical education in Nigeria. I believe that the Director of Hospital Services is also represented here. So, distinguished ladies and gentlemen, you are most welcome. So, my first question will be to the Chairman, Faculty of Public Health, because as an institution responsible for human capital development, and you will be playing a very significant role in this new program. I will want you to share with the audience what ways your faculty intends to modify or adapt your training program to help to contribute to this CRISP program. Thank you. Professor Oridota.
Thank you very much, sir. I bring you greetings from the chairman of the faculty, Professor Ogbonna. I'm representing him. This is a welcome development because the program we are talking about is anchored on our training, the training of our residents, especially to rural posting and urban posting. This means we really need residents to run the posting, and that's not the only posting they do. So to the teaching hospital, I want to appeal to us, let's employ more residents so that we have residents to post to all these areas we are talking about. We will also want to encourage our teaching hospitals to please support the rural posting, especially in terms of logistics, in terms of accommodation, in terms of transportation. Sometimes it's difficult to access some of these places where residents do this rural posting. The rural allowances that are paid to residents, some who are paying, I will encourage them to continue to pay. The ones who are not paying before, let's use it to give them the incentives. It's good that we start well. Our advice to the National Primary Health Care Development Agency, which they've already started. They've promised, because we started working on this program some months ago. We've been trying to design it and see whether it's something we could work out. And from what we can see, we can work it out. When we have challenges, we put mechanism in place to appraise it, and things get better and we remain focused. But they can support research that are focused on our objectives, on what we want to achieve, so that we achieve our aim. Also, to the National Primary Care Development Agency, we want to advise on sustainability, because there can be change of guards, and we still want this program to continue. To the department, especially the relationship between the department and the State Primary Health Care Board, because they will be involved. The State Primary Health Care Board will be involved in paying the incentives, some dues to the resident. There should be clear-cut demarcation in terms of responsibility. There should be, of course, mutual cooperation, respect, because the residents are directly under the department and they are in training. Maybe before I round up, I'm encouraged that our partners are already into it. We are glad to hear that, and we hope that it will continue. The faculty will support the program. It's not that we are going to reinvent the wheel. What we have on ground is adequate, is enough to take care of what we want to do, because it's more of supportive supervision. We have a feedback. We design some forms, some ways of reporting back what is happening. They can get real-time data to plan, to improve the system. And it's something that have been done, something similar to that have been done before several years ago, when we have model primary health care, like the Pakoto, like in some other states, and the teaching hospital supported the primary health care delivery in this country, and there was a lot of improvement. We are encouraged, and we hope for the best, and we know the health of our mothers and children will be better for it. Thank you, sir.
Thank you very much, Dr. Olufela. Will this be requiring modifying your existing curriculum, or how will you encourage teaching hospitals, federal medical centers to show more interest in the deployment of resident doctors to these primary health centers?
Curriculum modification is rigorous, very rigorous, and it does not really require any serious modification, because residents are there. And we are just lashing on what they do. There are things that they need to do. What we may just need to do is maybe one or two training on what is expected of them on the deliverables and ways of monitoring what we want to do. So it's not going to be any modification of curriculum, but we may readjust some of the things we do our priorities, what we look out for on the field, because it's going to involve service, it's going to involve research, it's going to involve supervision, and it's not all residents that go on rural posting. So if you have maybe 5 residents in a department, some will be doing several posting for them to go for their exam. So you can imagine for 3-6 months, no resident may go for any rural posting to support the PhD, and that's why we're encouraging the CMD, they should prioritize the employment of residents. The other thing, when you send residents to PhD at the rural area, and the light is not there, accommodation, they will be discouraged. So we need to start well. We need to do things that will encourage them, that will make them also to put in their best.
Thank you very much, Dr. Olufela. Now to you, sir, the chairman of the Executive Secretaries Forum. As we heard from Dr. Olufela, there seems to already be some presence of resident doctors in local governments, in primary healthcare centers. So I'm just wondering whether you would like to give us some examples of your collaboration with these training institutions. How have you felt their presence, and how can we enhance their presence at the primary health center? Thank you.
Thank you very much, sir, for that question. I think since I will be speaking from a colleague, I think it's a very great day to us as Chief Executive of State Primary Economic Agency, because without missing words, I'm sure if you ask 36 plus 1 plus FCT, Chief Executive of State Primary Economic Agency, one major challenge they have in primary care space is human resource for health. So zooming this challenge today will go a long way in history. And if I should cite cases where there's collaboration between the agency and the teaching hospitals or the tertiary institution within the state, let me start from my own state, Nasarawa State Primary Economic Agency. Way back 2017, we had this collaboration, a joint venture between the state and the National Hospital, Hospital Management Board, and the agency. There was MOU that was drafted between the state and the National Hospital, because at then, we didn't have a teaching hospital or a medical school within the state. So in that MOU, what we agreed between the state and the National Hospital is for the governor to key into that partnership, which he did. And part of what he's going to do on his part as a governor was to provide accommodation for the resident doctors that will be coming from National Hospital, and also provide incentives. It's a kind of incentive because we can't pay them. And it's going to run for, the residents are going to come from some key departments, pediatrics, O&G, surgery, and internal medicine. That was the initial phase. Then the second phase came ophthalmology department, because you know our deputy governor is an ophthalmologist. So that invested interest was there. So ophthalmology department came into it. So we had this arrangement. So the state governor built 8-man quarters in Mararaba General Hospital to provide accommodation for the purpose of resident doctors that are coming for that posting. And that has been going on since 2018 up to this moment as I'm speaking with you. And also there is this case study of the primary health care. We have a model primary health care in the city center, and that is the state capital, Lafia, called Kondere Comprehensive Primary Health Care, where we have 8-man quarters that is meant for resident doctors. There is this partnership that we signed with the University of Lafia, Federal University of Lafia, that is Fulafia, the medical college, to have their resident posted to the primary care center. Presently is ongoing. Also the state specialist hospital, there is this partnership we have with them. We sign an MOU with them. The residents within family planning, family medicine, the internal medicine, surgery, and O&G, they go there for rural posting. There is an accommodation meant for them. In that hospital, the ambulance, this is part of the agreement we had with National Hospital. So the state government bought an ambulance for the ease of movement of referrals in case they cannot handle within the space of primary care. And also we have another primary called Primary Care Shabu, which is not far from the state capital, Also, that one specifically is with the family medicine department. They post their resident there. They stay for minimum of 3 months to 6 months maximum for their rural posting. And minor surgeries are carried out here. Referrals are made to the teaching hospital within the state capital. I think these are a few cases. And also we know that in Ibadan or Ilori, they have what they call the COPS, Community-Based Educational Center. It's an arrangement that is being co-sponsored by the WHO, that resident doctors go for postings in the rural area. Why in Ibadan? We have this Ibaraba, in Ibaraba North Local Government, Ibaraba Central, and Ibaraba East. So there's a joint venture between the University Hospital, the University of Ibadan, and the local government. And thank God we have the Algon here. So once there's this agreement with these stakeholders, critical stakeholders, I think it's going to give a lot of results. But very important that I want to mention is we should leverage on the fact that we should use the state structure, the committee on health, because in the state, every state has committee on primary health care, which is chaired by the deputy governor. And among the committee members, you have the commissioner of health, the commissioner of finance, the commissioner of local government and children's affairs, the commissioner of education, the commissioner of women affairs. These are critical line ministries that are working with state primary care development agency. These are areas we can advocate for the needs for more resources to be pushed to primary care. We can also leverage on some projects within the state, like the impact project, the basic care provision fund. These are funding coming to the state. Let the federal government create that budget line for primary health care. For example, we are advocating for increase in the money that is meant for basic care provision fund, the 1%. Let us have at least a minimum of 2%. So once we have that 2%, a mark from the consolidated federal government revenue, we have more resources in primary care. Then we'll push more of these resources to support the primary care development agency. And I also advocate to the governors, let there be incentives. Incentives for health workers that are working especially in hard-to-reach area. Because you can only attract them to stay within this hard-to-reach area when there's security, when there's incentive in terms of money, transportation, accommodation, because they've lost a lot of things. Social amenity is not there. Education for their work is not there. So once state government and federal government are able to provide this for health workers that are working in rural areas, I think that will go a long way to retain health workers within the rural community. And also, let us have within legislation at the national level, at the state level, to ensure that exits of our staff, either through retirement, through resignation, death, is being replaced, because that is not in place. You only have that in very few states, where maybe when there's exit of health workers, you don't get to replace them. But if you have this policy and legislation on ground, I think it will go a long way to have more human resources for health in primary care. Thank you very much, sir.
Thank you very much, Chairman. Thank you very much. I am particularly impressed with what is going on in Nasarawa State. You know, I think that many states can learn from that. But can you, advise us on what major challenge, or they have no challenge at all in Nasarawa State, or what major lesson that we can learn from Nasarawa State?
Based on our experience, the major lessons that we have from Nasarawa State and the challenges. One, I talked about the issue of security. Then we talked about the issue of lack of legislation on replacement policy. Let that be in place. Because if that replacement policy is not there, sustainability is not guaranteed. Because we're talking about change of guards, new governor, new commissioner of health, new executive secretary. By the time these things are not legislated, when these exits of these governors or commissioner of health that have strong will and passion for health, there is that tendency that that program will not be continued. So I think legislation is very key.
Legislation and institutionalization of programs. Yes, thank you very much. Now I will move on to the chairman of the president of the Association of Local Governments of Nigeria. Of course, as you are aware, the federal government and the development partners have been advocating for having primary health care under one roof. This policy can only succeed with the cooperation of the local governments and its leadership. How can ALGON support and ensure the maintenance and upgrade of primary healthcare centers to national standard so as to create an enabling environment for crisp implementation and improved health outcomes? Thank you.
Thank you very much, Prof. First of all, we can confidently say that this program, ALGON is the direct beneficiary, because once the people at the grassroots are benefiting health-wise, ALGON will go to sleep. First of all, we'll ensure that each and every local government council in the country constitutes the primary healthcare advisory committee. Once this is done, then we'll go ahead to complement the state primary healthcare boards, which will ensure that, one, we provide a strong political will towards implementation of these health policies. Then we go after that to make sure that the infrastructures are provided and maintained, and also support capacity building for health workers to enable them to perform optimally and to attend all policies, all training, retraining being provided by the National Primary Healthcare Development Agency or the State Primary Healthcare Development Agency, knowing fully well they will always return to the grassroots and offer such services which will lead to improvement in service delivery. So we'll also ensure that the issue of equity, that is, let each and everyone benefit. There should be no segregation on who benefits from these services. You must not say that a patient, you give much priority to a patient who is a relative to a local government council chairman or to a councillor. No. Let there be equity. Let there be no segregation in obtaining such services. So we'll ensure that is being provided. And also, we will support the domestication of primary health care under one roof, operative guidelines, and minimum service package to all the PHCs within our jurisdiction. And thank God, most of the states have established national healthcare healthcare insurance agencies, which the local government councils have this law been domesticated in the state, and the local government areas too are under that law must have to key in by contributing their 1% or 0.5% as the case may be. And also, we ensure that the staff of local government councils also key in by contributing their 3%. I can confidently say, like my brother said, I can give example of Nasarawa State. That has been taken care of, and the contribution has started earnestly. And that our health insurance agency, in fact, is the people at the grassroots are feeling the impact, especially the workers. They don't need to have money at that point in time when either their relatives or the beneficiaries are sick. They always go, while at the end of the month, they don't even feel the impact of the deduction. So the local government or the ALGON are the ones driving this policy. And frankly speaking, as ALGON, we'll continue to give all the necessary backing and support to the State Primary Healthcare Development Agency, because they are always there for us. And we make sure that the constitutional or as the state policies or law requires of that 1%, which they are clamoring now to be upped, would support them in that direction, because we are seeing the impact. Most of the responsibilities, because primary health care service responsibility is supposed to be exclusive responsibility of the local government councils, but the state primary health care development agencies are doing this for us with adequate support from the National Primary Health Care Development Agency. As such, we have no alternative than to support them in getting the percentage being jacked up so that our people at the grassroots will enjoy more dividends of healthcare delivery at that level. Lastly, I will appreciate the National Primary Healthcare Development Agency, especially the ED, because during his tenure, ALGON is always been carried along in primary healthcare policies and guidelines, unlike before his assumption of office. That's why then we were always, in fact, in conflict, most especially with the state primary healthcare development agencies in terms of ownership, in terms of a lot of things. But which is coming, and with adequate partnership with the state primary healthcare development agencies, we come to know where our lines of responsibilities are. What are we expected to do? And we are made to know that we're supposed to be partners in progress, since the aim, the major aim, is to deliver health dividend to the people at the grassroots. So we really appreciate them, and will continue to appreciate them, and will assure them that ALGON as a body will continue to enlighten our members across the 774 local government areas in the country, so that the expected level of health delivery at the grassroots will be attained.
Thank you very much, sir. But I'd like to put you on the spot. One of the presentations, I think by the ED earlier on today, showed that many primary health centers or many primary healthcare facilities require some renovation. From the presentation we got earlier today, maybe only about 30% are in a fit for purpose condition. Can we get a commitment from ALGON, as to funding the renovation of primary health centers under your jurisdiction?
Frankly speaking, that is one area we are planning and we are focusing. And some states have started that, because we most especially those of, I can say, ALGON NEC members, we always give priority in maintaining or renovating such health facilities, like the one in the, if you go to Lagos, the one in our president's local government council is there, and also the one in my local government, Lafia. Thank God my brother is here, he can attest to that. And anytime they call on us, especially in maintaining, especially the vehicles, we were always there. And what we are looking at is how now we can provide accommodation as a kind of incentive or motivation to those that are working in the rural areas. And we'll preach that to our other members so as to make them not to try to run away from the rural areas to urban centers because of lack of certain or basic amenities. We'll try to do that by the special grace of God.
Thank you very much, sir. Can we give him a round of applause? So now Algon is committed to putting in more resources to renovate the primary health centers. They've been doing that, but they will put more resources. I think members of the audience will have the opportunity of asking questions at the end of the round of panel contributions. Before coming back to the Honorable Commissioner for Health, may I ask the Director of Hospital Services, Federal Ministry of Health, as the ministry responsible for supervision and regulation of teaching hospitals, what policy shifts would be required to enhance teaching hospitals in increasing the uptake of more resident doctors in public health and thereby increase the availability and participation in CRISP implementation?
Yeah, thank you, Prof. And good afternoon, ladies and gentlemen. I'm representing Dr. Salma Anas Ibrahim, who is also on another assignment in Lagos. When I got this brief, I debriefed this morning, I was very happy. Because some years back, together with some staff of the MKCDA, we were in Argentina on a study tour. And we are surprised to see consultants at primary health care level. I know some director of MKCDA that were in that study tour here. And we were thinking, how can this be possible in Nigeria? And this is the right way, and we are in the right direction. So having said this, Ministry of Health will not leave any stone unturned in supporting or strengthening the healthcare system in the country, especially at the primary healthcare level, to deliver what is intended purpose. Having said this, for the policy that needs to shift, one, we need to make the resident available. We know that health is on the concurrent list. Some say it's on residual lists. Well, whichever the case is, we know there are challenges in primary health care, even at the secondary health care, now at the tertiary. Tertiary now coming down to support the service or research or this effort at the primary level, which means we need to look at it. How many residents are the states providing for training? What are they doing to support training of residents? Because at the tertiary level, they also have some other things to do. So we need to sit down and talk on this. How do we encourage residents to come into community medicine? Do we have scholarship for them? Do we have incentive for them? Because community medicine or primary health care level is about the people at the grassroots. So it is not people just coming to do residency, but are they ready to live with the people there for that short period of time without complaining, be part of the people there? So how many doctors, resident doctors, are local governments supporting to undergo this training? How many residents is the state support, sponsoring to do residency? Yes, we know we need to improve on the infrastructure at the primary health care level. So having said this, we need to critically examine the dynamics and actions of stakeholders involved in this. It is not just an MOU. We need something stronger so that we can call ourselves to question on why are we not performing? Why is this thing that we agreed on not going the way we want? Thank God the college president is here, and the faculty chairman of National Postgraduate Medical College and Faculty of Medicine. we need to see if we can bond the residents that are coming from that locality. It's already taking place for first degree. It depends on what you are offering them. Give them what they need. There have been a lot of discussion on how to retain residents, even after their training in the ministry. Those are part of the thing the Honorable Minister mentioned, providing comforts for them, give them housing loan, give them car loan, give them what they are going to look for somewhere else. When you make it available in that community, definitely they will be ready to go for that. Yes, we are aware of the community, urban PHC and rural PHC that we are doing the posting, but they cannot do all. You know, they cannot spread all through. Probably a teaching hospital is taking like maximum of 10, which somehow we will not, 3 per senatorial district. Yes, it's something, but we need to, the state also needs to invest more. The local government needs to invest more in this area. Then the issue of brain drain, yes, government would like to do more. I mean, federal government would like to do more. But the issue of brain drain is already a big problem on our hand, which all of us here know. So the teaching hospital, for them to prioritize residents in community medicine more than others, because they are for really curative, majorly. The preventive is down there. Who are the stakeholders that are supposed to be involved in the curative, in the preventive aspect? What type of discussion is going on amongst ourselves on how to strengthen this level? Then the facilities, we learned that about only 22% of the facilities available, PHC facilities available, are somehow usable, or you can say this is really PHC. Who is expected to do all this? What level of government is expected to do all this? I was in Igbora that you mentioned. Igbora, the facilities in Igbora was, you would love to go there. But if other areas are like that, I'm not sure of now, if others are like that, residents would like to go there. These infrastructures, who are supposed to fix those? So what I'm saying in essence is that the stakeholder, the critical stakeholders need more in-depth discussion and agreement on how do we tackle this. This is a beautiful idea. We have seen it work in other countries. It's possible for it to work. But it is not just on, I know, you know, we agree. We need an in-depth discussion. The 2% you are advocating for may not even be sufficient enough. If PHC is fixed, the tertiary facility will be addressed, and they will do what they are supposed to do. We cannot have quality care services in Nigeria if we do not fix the primary health care system. Thank you.
Thank you very much, DHS, and I like that particular phrase. If PHC is fixed, then we'll be able to fix the Nigerian health system. But I'd like to put you on the spot. If the PHC system is capable of solving up to 70%, 60 to 70% of the health problems of Nigerians, is the DHS or the ministry considering a possible policy shift in giving directives within the existing funding envelope to tertiary institutions to take in more residents for public health and primary care training? That is, even within your existing funding envelope, will you be considering a policy shift to encourage teaching hospitals to admit more residents for training in public health and primary care, since we know that 70% of the disease burden can be handled at primary care level?
Yeah, thank you, sir. The college president. You know, training resident doctors involves...
Sorry, my other faculties are not going to like me for that.
Faculty chairman. See, training resident goes beyond giving instruction. There are facilities, there are infrastructures that you need to put in place. Supposing Ministry of Health now said, employ 100 resident doctors within the envelope that you have. They will also tell you the other competing departments that needs that. So, and the faculty chairman will also say, this facility you have is not fit. Therefore, because I was in Aminu Kano Teaching Hospital 2 weeks ago, the Kumboto Health Center, the faculty, National Postgraduate said, no, this cannot be used. You have to go to a particular place. I know you remember that. So it's a discussion that needs to be taken beyond this level. And college, the National Postgraduate Medical College is semi-autonomous. Thank you, sir.
Thank you very much, the DHS. Thank you for your input. Now to the big masquerade, the policy maker at the sub-national level, the Honorable Commissioner for Health. A lot of conversations have been going on for private sector support to primary health care centers. CRISP provides linkages for primary, secondary, and tertiary levels of care by mobilizing human resources for health. As a health leader at the subnational level, what are your recommendations to the private sector to facilitate their support for primary health care and human resource for health availability for optimal service delivery? Thank you.
Thank you very much for allowing us commissioners to lend our voice to this very important discussion as the implementers at the subnational level and major stakeholders. When looking at the private sector, we need to look at it at 3 levels. The large industries, the pharmaceutical industry, which is very pivotal to the success of any health system. And lastly, the private healthcare delivery companies, firms, providers. So with the large pharmaceuticals, they have various roles. The last speaker was just talking about infrastructure. There's an initiative that's been started by, I think it's the Igi Mokwede Foundation, which is called the Adopt the PHC, which involves the private sector coming in and upgrading the facility, which would then make it conducive for registrars to be able to train in those facilities. They can provide accommodation whilst upgrading, make sure that PHCs that don't have accommodation have staff in accommodations. They could actually sponsor registrars. There is Leventis that sponsors graduates, people to undergo undergraduate training. So you could have big companies that sponsor residency programs. And they could also partner with the government in providing incentives, because we have to be conscious of the fact that the government can't do it alone. IGR in some states, it varies state to state, and you cannot build a health system that is based on the IGR of a state, because then we're going to have inconsistency in the quality of healthcare that our citizens receive in various states. So we can't, so we have to leverage on the private sector. And given that 70% of our citizens actually access care from the private sector, we can't leave them out. The second tier that I was talking about is the pharmaceuticals. They are efficient in delivery and making sure that each naira is spent efficiently. They have the skills, they have the efficiency. As commissioners in the last 3 years with the pandemic, what we've realized is the efficiency is a bit lacking in the existing structure. And it's not in Nigeria alone, it's globally that you find that governments, it's a bit clunky to make us work more efficiently and spend our money efficiently. So by leveraging on what the private sector has to give, they can even build up capacity by having like PPPs, where you have a healthcare provider, a private healthcare provider, moving into a government facility, running the facility. So you have like a franchise In America, it's the private sector that provides healthcare, and the government is the payer. And that takes me to the universal health coverage. We cannot shy away from universal health coverage because that is a way of sustainable funding of healthcare. Luckily, we've been using the basic healthcare provision, which has been very, very useful for us at the sub-national level. We've used that to make sure that there's no stock out. Some states like mine, we've actually employed health workers and paid them from the basic healthcare. The local government is paying healthcare workers, doctors, from their capitation and also the interest they receive from basic healthcare provision. So you can actually, we have to make sure that the private sector, also the industry around the community, actually enroll their workers into the insurance, the state insurance program. By doing so, they ensure productivity. If they can, if their health, if their workforce is healthy, then they're more productive. They make more money and they impact their community. I recently had one of the communities PHC renovated by an industry that is in that community, that employs from that community and has committed to actually buy the state insurance. And that means that the capitation goes back into that community. So those are the various areas. The private healthcare providers are the last group of people, and they can actually take franchises of clusters of PHCs. What would that offer? That would offer a higher quality healthcare provision, also provision of health worker, HRH for health, because they seem to have more workforce than we have in the ministries. So by these three layers, we can engage the private sector and ensure that as states and nationally, we have quality health care. For instance, just to round off, in England has actually franchised out all these GP surgeries, which is the primary health care. The GPs own the surgeries, and the government pays them for the services per capita. And they, in turn, can invest in their practice and be competitive. Once you introduce competition, you introduce quality. So I'm going to rest my submission on that note.
Thank you very much. Honorable Commissioner, the federal government support to states on human resources for health through the EMSS is estimated to be for about 4 years, and an MOU is in the process of being signed between federal government and states. What will you recommend in guidance or as guidance to states to guarantee the retention and sustainability of the EMSS health workers, recruitment of nurses and midwives? You know, after 4 years, then what happens?
Thank you very much. We have what I see two ways in which we could sustain that. One I mentioned is the basic healthcare provision can be leveraged upon. All states get that on a regular basis. There's also pushing for a health insurance scheme. There's no way out. That's the only way the government can consistently, the government of various states can consistently ensure that health workers will get paid. And my brother mentioned earlier on that when there's attrition, we should have policies that ensure immediate recruitment, replacement of that attrition by retirement or by moving on to greener pastures. Thank you.
Thank you very much, ma'am. Your Excellencies, as we begin to wind down, there is now opportunity for questions from members of the audience. Questions? Yeah, okay. I don't know who is going to assist us. So 1, 2, so we have 2 questions. The first table here, and then the gentleman at the back. Yes, yes, please. And there's a lady down there, so that there's gender equity.
Good afternoon, panels, my senior colleagues. My name is Dr. Muhammad Samba Al-Ghali. I'm standing in here representing the Honorable Commissioner, Minister of Health, Bauchi State. I am pleased to be in your midst and this very, very important discussion. And I really, feel like how I wish I've been part of this innovation that has been developed by Dr. Faisal. Simply because this has spoken my mind, and I want to really share, a little experience from my background. I am the Executive Chairman, Hospitals Management Board, Bauchi State, and I've been working for more than 10 years in the secondary health facilities. First of all, after appreciating this very, very important and laudable, innovation that will, stand the test of time in addressing most of the problems we are facing in our healthcare delivery system. But I want to, bring to our notice that we're all aware, the nature of healthcare system in this country, where we have primary, secondary, and tertiary that is enshrined in Nigerian law. Having said that, we need to look at the system in total as an entity. We are all aware that this issue of human resource for health has eaten rooted into the whole system, not only at primary health care level. In fact, from where I am talking and from my background, I would say secondary health care has been neglected and rejected. Simply because if you look at the system, the tertiary.
Because of time limitation,
okay.
I will request
to summarize.
some
Okay.
brevity.
Thank you, sir. My question here is, we are all aware that human resource for health is a problem across, and I want this body to look at this very, very important innovation in trying to see how we can, bring them together so that it will address the two areas at a time. I have also developed such model, hub and spoke model, that is here over time. But because I don't have a voice, maybe that is why it has not been answered. If we look at that area, meaning that why don't we have a system whereby primary health care will be clustered along the existing structure of the secondary health facilities that we already have? This is a system where a hospital is already in existence. We're talking about the infrastructure, accommodation is already at the secondary healthcare level, and all these secondary healthcare facilities are domiciled in our, local government areas. So if we go by that, and we need to go back and do maybe a cost-benefit analysis of how much investment are we going to do to be able to get to where we are, or rather attain the 70% of healthcare coverage from the primary healthcare. But looking at it together as a system, we may cluster this chip in such a way that a secondary healthcare facility will be improved, to address a cluster of the primary healthcare within that environment.
Thank you very much. I must commend you. You very brilliant ideas here, but some states are already doing it. The Commissioner for Health Ogun State has been doing something similar. May I suggest to you, sir, that you can actually write in any of the journals, and there are many journals in Nigeria. Your ideas can get across. So don't assume that you don't have a voice. You need to put pen to paper and publish, and then you'll be widely read all across Nigeria. The next contributor, please. Yes, please. Please, you have only 30 seconds for your question or comments.
Thank you, sir, and the panelists. This is a real-life event. We were at a PHC supported by, as an annex for a teaching hospital. And we look at the record, 11 personnel, and in a month, 2 deliveries. And then we went back 3 years. And you actually saw this particular PHC peaked and had previously had 10, 20 deliveries per month. prior to that engagement. And we asked the question. They said immediately the place was taken up by the teaching hospital, the community just disengaged, completely disengaged, and will not patronize that PHC again. And the data were all there. But the personnel were still coming, salary was still being paid, the place was renovated, but the community will not enter. So my question is this, that there are existing models all across the country now, that where you have the teaching hospital currently taking charge and they are running. Have we done some bits of baseline to say what models are working and what models are failing and why are they failing before we now scale the various models that we may be thinking about? Thank you.
Thank you very much, sir. So we need to conduct some operational research, and I believe that the MPHCDA is taking notes of that so that we can know which models are working and why they are working and which models are not working. The lady at the extreme left.
Okay, good afternoon, everybody. All protocols duly observed. My name is Iweze Rose. I work from Environmental Management and Occupational Health. My question will be to the chair and the faculty lead. Is there any place where occupational health can play a role now that is in the developing, the CRIPS is in the developing a curriculum is in the early stage? Can we bring in occupational health, and safety too, as a curriculum, as part of the training topics or manuals, and even environmental health? Thank you very much.
Thank you very much, ma'am.
Yes, sir.
I'm going to give the panelists 30 seconds each to make a final intervention before we round up. So I'll just start from the chairman of the ES Forum.
Thank you very much. I think the question that I will address is around the issue why, when you have human resource for health coming to primary health care, suddenly the patients stop coming. I think when you were talking about that, I think I was just laughing because we have that experience in Nasarawa State. One of our primary health care center was a health post that was upgraded to comprehensive health center. Then doctors were coming around. Suddenly, the community withdrew. That they don't want the comprehensive primary care, they want their health post. And we did a baseline, a source of baseline search and check to see why. Simply it's because of the fee. There was sort of increase in the charges as against when it was a health post. That is the basic reason why they are not coming. Not because of not because they don't want to see the doctors, not because they don't want the primary health care, but if the fee is at par with what happened in any primary health care center or primary health post, you will see them coming in their thrones. And also I would advocate that you should use the community structure. They have what we call the Ward Development Committee chairmen who are fabric within the community. There need to be a lot of awareness, advocacy to community people to know and to see why that is happening. If that is not done, that attrition or withdrawal will be there within the community. Thank you.
Thank you very much, ES. I will now move to the president of Algon for your 30-second intervention.
I will still reiterate on our readiness to continue to enlighten our members with a view to giving all the necessary support for all the innovations by various agencies so that the people at the grassroots will benefit the most in terms of primary health care deliveries at that level.
Thank you very much, sir. Honorable Commissioner.
Thank you. The delivery of a quality primary health care service is dependent on the sustainable financing through insurance, the collaboration, leveraging on the efficiency of the private sector, and the support of our partners. Thank you.
Thank you very much, ma'am. The DHS.
My last point here is that in embarking on this journey, we need to critically examine dynamics and actions of each stakeholders, including the social actors involved in health, with regard to a particular environment. Because what happened in Kano and what works in Kano may not work in Port Harcourt. So the social peculiarities, the environmental peculiarities need also to be factored in for the success of this journey. Thank you, sir.
Distinguished ladies and gentlemen, as we come to the end of this panel discussion, I will just want to draw attention to some of the key points that were raised. The first one is the need to incentivize rural health workers so that they can accept postings and remain at post. The second one is to prioritize the training of primary healthcare workers, and chief medical directors are to be encouraged to increase the recruitment of resident doctors in the field of public health and primary care. There is also the need for political and legal framework for the contribution of stakeholders, maybe in form of MOUs or in form of legislation. And there is the need to ensure that state primary healthcare boards are constituted in all states. I think, and then the Honorable Commissioner drew attention to some strategies, including the adoption of primary healthcare facilities as a policy, so that it can encourage the private sector to participate more in the provision of primary healthcare services. I would just like to, on your behalf, thank these members of the panel for sharing with us their wealth of experience, and I will ask us to give them a round of applause. I think with that, our assignment is done. I don't know whether Auntie Moji is around to take over. Are we permitted to take a group photograph before we go? Can we take it off stage?
Thank you. I've been told that we have participants online. I want to thank you also for participating, and thank you so much. All the presentations that have been made would be online, so you can log into www.nphcda.gov.ng. Right, we're moving on quickly. The day is far gone. I'd like to invite Professor Clara Ejembi, who is leading the team for the communique. She has promised me that she would speak to it because we'll get the full text of the communique online. So please, let's put our hands together as I invite Professor Clara to Ejembi to please come forth with the communique. Can we please have the podium back? Thank you. Yes. Because she would need to place the laptop on it. Thank you. Yeah, it's okay. Come. Who are the people signing? The people that will sign the MOU at the national level? Yeah. The names of the what? No, the people that will sign the No, I'm not going to call them. Isn't it when later? It's not later now.
when they finalize. It is a draft, no? So all protocols duly observed. I'm presenting the draft communique of the launch of CRIPS. Because of lack of time, I may not be able to read through what we've written, so I'll just speak to it. The communique has a preamble that states what the launch is all about, including the theme, which is optimizing primary healthcare resources for health. Optimizing primary healthcare human resources for health, key to reimagining primary healthcare. It speaks about the people that were present and the contributions they made to the launch. We've also identified all the participants, and we observed that the meeting provided a platform for raising awareness about what CRIPS is all about, and it also sought to secure the buy-in of all the stakeholders as we work towards improving primary healthcare in Nigeria. The participants at the meeting, we observed and we acknowledged that primary healthcare is the foundation of our healthcare system. It is also the bedrock of our national health policy, the key to the attainment of universal health coverage, and the attainment of health for all at all ages, which is the SDG 3 goal. We also acknowledge the PHC summit that was held and the four-pronged agenda for PHC transformation in Nigeria. And we also recommended that actions should be expedited to ensure implementation of this agenda for strengthening primary health care in the country. Based on the deliberations, we acknowledge with dismay the very poor health indices of the country. In spite of the interventions and programs, our healthcare indices compete with the worst in the country. We have the highest number of maternal deaths. More than a quarter of maternal mortality in the world is contributed by Nigeria. We have the second highest child under 5 mortality. And all of these are because of our weak healthcare system, especially primary healthcare. We noted the dismal statistics from the assessment of the primary healthcare under one roof that was held in 2022 in the country, noting especially that just about 3% of our health facilities have the basic minimum, meet the basic minimum standards of PHC level 2. We also noted that 60% of the facilities do not provide services like postnatal care, 40% do not provide antenatal, and that results in underutilization of services. And very fundamentally, we note that human resource is critical to service delivery. We cannot talk of, we may have the resources, whatever are the inputs. If we don't have people to provide the service, we can't deliver on primary health care. The assessment found only 3% of our facilities in the country, the world focal facilities, meet the minimum standard of human resources for health in terms of full-skilled birth attendants. And obviously, if we are to move forward, we must have not just the adequacy in numbers, but we must have health workforce fit for purpose and fit for service. Health workers that are available, accessible, and equitably distributed. We noted the CRIPS strategy is an innovation that is aimed at meeting the human resource gap and strengthening primary health care by leveraging on
human resources available in our tertiary health institutions to support service delivery, mentorship, and capacity building at lower levels. And we note that if implemented, it can equitably expand coverage and access to services, and especially improvement in quality of care. And it will improve confidence in our services and contribute to accelerating progress towards universal health coverage. We identified factors that could drive the success of the implementation of the CRIPS, and that includes political will at all levels, stakeholders abiding by MOUs, aligning the community medicine public health rotations to support CRIPS, resources to support logistics, supervision, and research, and strengthening of coordination and developing a sustainability plan. Additionally, incentives and accommodation must be provided by government for the skilled birth attendants to be recruited as part of the program. And state governments should legislate on HRH and institutionalization of CRIPS. Participants applauded this innovative collaborative strategy for bridging gaps in human resources for PHC and for increasing access to quality service. And to this end, we resolved as follows. Number one, to align our programs and resources to support PHC, CRIPS. The NPHCJ will drive the program, mobilize resources, and provide technical leadership. The states and ALGON will implement national policies, drive the implementation of primary healthcare under one roof, and provide an enabling environment for the implementation of CRIPS in their states, while the national and West Africa postgraduate medical colleges will support CRIPS, and tertiary institutions will ensure employment and deployment of adequate number of residents in public health to selected PHCs in line with the CRIPS strategy. Partners have committed to providing financial and technical support to ensure the success of CRIPS. We also resolved to mobilize resources to strengthen primary health care generally in the country, and finally to work in synergy and mutual trust with all relevant stakeholders to implement the MOUs that will be signed shortly. And finally, there are appreciations, and the communique will be signed by the Federal Minister of Health, the NPHCDA, representatives of CMDs, states, departments of community medicine, and other key stakeholders. So that's where we are. If we miss anything, so if there are any other inputs, we'll take it as it's a draft before it's finalized for signature. Thank you.
Thank you very much. Before we have the vote of thanks, we are going to have the national signing of the MOU. And I have a copy here. I understand that some states brought theirs, or is it a communique that the states brought? Please ensure to submit to the Secretariat. I hope I have the clear information of what you're to do. You can see that this table has been permanently featuring since the beginning of this event. I'd now like to call the following people to please take their seat at the table here where the MOU will be signed. The Executive Director and Chief Executive Officer, National Primary Healthcare Development Agency, please can we lead him to be seated? Chairman, Forum of Commissioners, Dr. Oyebanji Filani, please. Dr. Oyebanji. Oh, okay. Okay. Chair, Forum of Executive Secretaries, Dr. Usman Adis. Representatives of CMDs, CMD UCH Ibadan. Okay, representative of community medicine, Professor Kofoworola Odeyemi, head of Department of Community Health, LUTH. Representative, National Postgraduate College, Dr. Olufela Oridota, please. Thank you. Representative, West African College of Physicians, Professor B.S.C. Uzochukwu.
Is this a copy? E.T. Oh, no, she not copied it. Okay. I'm almost sleepwalking.
I would expect that Dr. Garbai will be ready to take for the tour of the exhibition stands. Yes, but that will be after the vote of thanks, and Dr. Ngozi Ngosu would move the vote of thanks.
Refreshment to the right side of the place, huh? What's that?
Okay. And shortly after the vote of thanks and tour of the exhibition stand, light refreshment has been made available. So please try and visit the stand for the light refreshment to up your sugar level. Hello, Dr. Ngosu, please.
That's what I'm trying.
Yeah.
Sir?
Dr. Leila. Please, can we have the vote of thanks, please?
Okay. Your Excellency, the Vice President of the country, Professor Yemi Oshibanjo in absentia, the Honorable Minister of Health, Dr. Ehanire Osagie, our able minister, distinguished guests, please permit me to stand on already established protocol. On behalf of the Executive Director and Chief Executive Officer of MPACDA, Dr. Faisal Shoaib OON,
as well as the board, management, and staff of MPA-CDA and the local organizing committee, I stand before you today to express our heartfelt gratitude and sincere thanks for your presence and invaluable contributions to the launch of the community-based health research, innovative training, and service program, CRISP. We are deeply honored to have the distinguished presence of our esteemed Vice President represented at this event. His unwavering commitment to improving health and the well-being of our nation's citizens has been very exemplary. And his presence today, represented by the Minister for Women Affairs, served as an inspiration to us all, reinforcing our belief in the importance of the CRIPS program in achieving sustainable and quality primary health care for all Nigerians. As an agency, we would also like to express our profound gratitude to the Honorable Minister for Health, Dr. Ehanire Osagie, for gracing this occasion. He has always stood by us as an agency, and his esteemed presence today goes to show that his support has been from beginning till the end. His expertise, his support, and his dedication to transforming primary healthcare in Nigeria have been instrumental to driving the positive change we have seen in primary healthcare in this administration. His tireless efforts to ensure access to quality healthcare services for all citizens of Nigeria are truly commendable. To our esteemed representatives of the donors, UNICEF, WHO, BMGF, and all the rest, our private sector partners, the traditional and faith-based leaders, members of the Nigerian Governors Forum as exemplified by the Governor-elect of Kano State, our legislators, and etc., we extend our deepest gratitude for your unwavering support and commitment to advancing primary health care in Nigeria. Your generous contributions and partnerships have played pivotal roles in making this CRISP program a reality. Your presence here today signifies the strength of collaboration and collective efforts needed to bring a sustainable change in the healthcare landscape of Nigeria. We would also like to acknowledge the immense efforts of many of our other stakeholders, the Honorable Commissioners of Health, the Chief Medical Directors of the teaching hospitals and the Federal Medical Centers, the Head of Departments of the Community Medicine Departments, and indeed several other departments, including the Family Health Departments, the Pediatric Departments, and several other departments that have partnered with us now and even before now. Even the Department of Obstetrics and Gynecology that had partnered with us in the past. The Medical College, the National Postgraduate Medical College, as well as my own college, the West African Postgraduate Medical College, researchers, healthcare professionals, leaders, traditional and religious leaders, as well as members of the fourth realm of the estate, as exemplified by Auntie Moji and her team, who have worked tirelessly to ensure the success of this program. Your dedication, your expertise, and passion for improving healthcare services in Nigeria, especially at the grassroots, have been responsible for driving the efforts that we have today and for the birth of the CRIPS program. Furthermore, our gratitude extends to the organizing committee, the volunteers, even those that we did not call, the several people that have worked with us behind the scenes for several weeks running, who have worked relentlessly to make the event a grand success. Your commitment, your attention to detail, your hard work, our board chairman and the members of the board, our ERC members, several other teams that are here present, we are grateful. Your efforts have not gone unnoticed, and we deeply appreciate them. Last but certainly not the least, we would like to express our heartfelt appreciation to all the participants that joined us both physically and virtually. Your active involvement and engagement, as well as valuable insights, have added immense value to these events. Your presence demonstrates your unwavering support for the cause of primary healthcare transformation, and we are really grateful for all your commitments. In conclusion, today marks a very significant milestone in our collective journey towards improving the quality of primary healthcare services in Nigeria. The CRIS program, coupled with the launch of the policy documents to improve and guide implementation of primary healthcare in Nigeria, sets a strong foundation for the transformation of primary healthcare in the country. We remain resolute in our commitment to this cause, and with your continued support and collaboration, we are confident that we will achieve our shared vision of a healthier and a more prosperous Nigeria. Once again, on behalf of my Executive Director, Dr. Faisal Shuaib, we express our deepest gratitude to each and every one of you for your presence, your contributions, both financial, material, and otherwise, your unwavering support, etc. Together, let us not be tired. Let us continue to forge ahead on this path of progress and make a lasting impact on the lives of every Nigerian towards our vision of making every Nigerian healthy. Thank you, and God bless you.
Thank you very much. That concludes the agenda for this historic moment. My prayer is that CRIPS will be sustainable and will be one that will be a legacy that would live for the growth and development of primary health care in Nigeria. Thank you very much. Thank you, Edie. There'll be refreshment. Yes. By the, I guess, when it's refreshment, you know, this is primary health care, so we should actually be eating at the, you know, at that level. So please enjoy this upwardly interesting refreshment, which is also giving us hope for a better primary health care. A couple of announcements. Please go to the transport desk for you to get your free card that will enable you to take your vehicle out without having to pay. And of course, if you haven't registered, any other announcements before we call it a day? Thank you very much, Nigerians, for giving me the opportunity to be part of history. The exhibition stand is by my extreme right as you go through this door, led by the Executive Director. We thank you all. Enjoy your stay and continue to pray for a better Nigeria. God bless you. Led by Dr. Garba.
Why the registration? Why the transportation places? Thank you very much. I'm sure many of our participants here must have seen some of the documents. Please, can we come and see the stands? Can we start from the extreme right? Yes, yes, sir. So please come. This is Sidani Group, one of our partners that has been very helpful. No, he said we should start here. No, he's going to. Come here, come here. This is the starting point. This is the starting point. Please, can we come? Please, can you come here? This is the starting point. This is the starting point, please. Yeah. This is Danny, one of the very helpful and very cooperative and highly skilled technical partner supporting NPSCDA day and night, no weekend, no working day. They are here, so please can you talk to them by yourselves? Yes, Sidani.
Good afternoon, everyone. Good afternoon. My name is Hilda, and I'm a senior associate with Sidani Group. We're a management consulting firm, and we provide support across a range of sectors. We are majorly domiciled in the health sector. We have different strengths, from health system strengthening, we do demand generation, supply chain, and even assessment. We supported the PAC assessments that was just concluded in all the states, and we're also supporting the EMSS program under the CRIPS for the recruitment. So you can go to our website to learn more about what we do, and we have something small for people.
Thank you. Thank you. Let's go to the next. Let's go to the next. Yes, here is we have one of the documents here. You are here already, so can you explain to them what are you doing here?
Yeah, this is. You're welcome, sir. This is Clinton Health Access Initiative. We have been supporting. This is Clinton Health Access Initiative, CHI Access Initiative. Yeah, we have several donors, and we've been supporting this federal and state level around primary health care strengthening and health financing across several states, particularly 7 states focused right now. And we have been working closely with the states' primary health care development agencies and their state health insurance agencies to help strengthen their primary health care infrastructure. And we went into the communities to sit with these people and understand what exactly their problem is based on the findings of the NPSCDA assessment so far. And we have used that to relate with them and also see how we can work with the communities, their traditional leaders, their ward development committees, and some of the key change agents in the community to see how we can bring out plans to bridge these gaps with them, developing good improvement plans that they can use their NPSCDA money in disbursements to work on improving these things and bridging their gaps, while we also work with the state insurance agency in the other side, as you can see, to help enroll the poor and vulnerable people in their communities into the health insurance programs. Right now we have a target of over 120,000 people that we're looking to focus on in the next 3 years to get them into the scheme, while the state continues to cater for all of them as primary health care is concerned. So what we have been trying to do and what we have achieved so far for some of the states, particularly in Kano, Kaduna, and some other places, Niger, we've been able to ensure that some of the facilities are operating 24 hours. They have the basic infrastructure they need to operate for 24 hours, to have the right security, they have the electricity, they have all of that already. These are some of our work that we can show across board. So we are still looking into making sure that we ensure that we reduce some of these indicators that are really bothering both the national level stakeholders, because we cannot. No, we are not in Abia for now. We are not in Abia for now. No, we are also in Bayelsa. We're in Bayelsa, we're in Rivers. Okay.
Let's move. For those that have more interest, they can come back and discuss. Yes, these are some of the documents we have produced. Yes. So can you explain, please?
Yes, sir. Yes, this is the summary. This is the summary of all the states. And this is the dashboard that represents all that was done from the PAC assessment. This is just in summary. Yes, sir. This is Ondo. Kano is over there, sir. Kano is over there, so we just have 2 states. Okay, Ebonyi over there. Jigawa is over there. So sorry, sir. It's a pamphlet. You just speak.
Okay, please, can we move to the next? Can we move to the next step? Yes. Here we have the CRIPS document here. This is the CRIPS stand. Yeah, so can you tell them what your people are doing?
So we have the operational guideline for CRIPS.
Yeah, talk now. Let's talk.
Okay, we have the operational guidelines for CRIPS, and we have the strategic plan for CRIPS as well. Then we have the HRH strategic plan for 5 states there. Then we have the frequently asked questions on CRIPS as well. Yeah.
Very important. So these documents are reference materials. Which
yes.
Are the guide. We need this. I assure you, in the field, they need this to operate.
Yes, and you can also get it on the website, agency website. You can just log in and download it there.
A lot of work was done really to put this thing together, okay?
Yeah.
So please, you can check through the website for detail, but you can still dash them with something here now. What can you dash? Okay. Next one. Please. This stand is for public now. Can you talk to the public, please? It's not individual again. I'm with the team. Come on, stop. I'm with the team for now. Stand up and speak. Stand up. Talk to the team. Please, yes, can you come and listen? Yes. So what are we doing? What is this place for? Talk.
So this booth is for PSCSD department.
Yes.
Primary Healthcare System Development. So here we have some documents that we've launched. We have the scorecard 6.
Scorecard 6, where we say this is how we are performing primary healthcare. How can they get this?
Okay, so we have hard copies and then we have soft copies on the website, MPSCD website. So
Are they for you to have this now?
Yes.
So please, what did you get one? Yes, have you got one? Please, you need this. You need this scorecard 6 to guide you. Okay. Please, you need it. Okay, you need this scorecard 6, please. We need it.
I have one. That's it.
Which one is this?
Standards and regulations.
You need this. Okay, next. Here. Please, this is the last stand before you eat. This is the last stand.
No, you register. We are going around, yeah. When you came in, it's hard to. So we are going to cross-check it.
I speak to the team, not to the individual. Please come and listen. What is this?
This is the PhD strategic document, sir, for the agency. Yes, sir. It's the 7-year work plan.
We suffered on this.
I'm going to take 2 breaks. Alternatively, we have the soft copies available on the website.
For soft copy, we can pick this.
You put your name down if you want the hard copy, and the soft copy we have them on our website. So these are just preview copies.
Thank you.
So that. This is your organization.
So one of these, right?
No, sorry, we will send it to you.
Soft copy?
No, the hard copy.
Soft copy.
The hard copy.
How much
The soft
is that? Sorry, they go, I will download. Okay, yeah.
They won't understand. So they don't believe in the song. No, it's not uploaded on the. It's on the website. Not very slowly. It's on the website. Just upload it. I think the network is slow or something. Alright. Thank you.
Yes.
So imagine if this thing was plenty now. What happened? Everybody wants a copy. So it's better we maintain it.
So the people TV said was they should codify it, lock it in a PDF that cannot be editable and put on the website and send it out. That's
It's
what
already
said.
on the website. But people want
So
to
can you tell them it's there? Can you tell them?
You know these people, they want souvenir.
What's here? Welcome. Good afternoon. What can I pick here? Well, this and this. This one we don't have enough yet. So if you want a hard copy, you drop your details report. We have some copies PDF version on our website. Yeah, you can leave it and your organization.
Bye. You can go and check in your parking lot. But if you do it, you have to leave immediately. If not, you start counting. And no, like you can do it now. But if you just do it, you have to leave. To ku fara rage mana ba BTO officer je ba. Ku soka da wannan let's put it and go.
Can I pick one? So it's just preview copy, sir. We'll have the hard copy sent to you.
No email here. For you, sir.
No, just.
You registered in the front desk. Yeah, that's what you use for no problem. What's your organization?
Oh, sorry.
So I can pick one, right?
In that abani wannan ya kan
We sent to you. Yeah, we sent to you.
No. Since we've already broken it.
Okay, let's say the soft copy on our website. But you can have this. This is the open agenda and this is the national agenda.
Recording stopped.
There's a way I want it. If you stand up, it will be everything. I want the rights of everything to come up. Come now. Sorry, I want you to be more better. Okay. Okay, just give me everything that captured. Thank you. Thank you. Just be snapping me alone before how. Thank you. Come on, sit down. Thank you very much, sister. I sit down. Thank you, sister. Thank you very much. You snap you was another one again, ma? Huh? Maybe another one again. Since I'm wearing my card now, I have been talking to you. You sit down here. Remove your small bottle. So you are not able to network. Okay. Thank you very much, sir. At least I was ready to come for this.
Okay. Let me. You could go back a bit. Don't fall. Oh. Don't fall down. Oh. I hope I'm good. Okay, the microphone. That's fine. Yes, I need the background. That's the. Don't fall down. No. Could do a portrait and. You're able to get it? Yeah. Okay. Thank you. Okay, let me start.
Let me join you now. I said, let me join you here now. I think you want to sit down, so I will join you. Yeah, come.
Let me just have you snapped? The snap is safe. But it's not close.
You can see that. Let me snap one. You see that? I use Snapchat, right? I will not allow the chairs to show. You will not allow the chairs to show. See what I'm doing? No. Understand it?
Voila.
See.
Okay.
You understand what? Yeah, because everywhere will be empty.
Yeah, okay, I understand.
Yeah. my phone is. Let me see. I like this. Wait. I'm seeing another big picture here. Yeah, I love it.
It's fine.
See, I love your dressing. I love your.
see the picture just now? You see? You see? See the pictures? Most especially this one. See how this one is?
Okay.
You see? You see? That is much because the chair, I didn't know are there, the chairs are empty. So please, you understand? Sorry. You can sit down, sit down. How would I?